learn from scaling one of the largest mobile health communication programs in the world. Hi, my name is Sara Chamberlain, and I'm the Digital Director at BBC Media Action in India. BBC Media Action is the international development NGO of the BBC. There has been exponential growth in the number of digital development programs seeking to leverage technology to solve systemic challenges. Particularly during COVID-19, there has been a rush to digitize. However, despite promising results and a shift from pilots to scale-ups, many interventions have failed to realize their full potential. In India, one of the reasons for this is the digital gender gap. According to the GSMA, before COVID-19, India was set to become a smartphone superpower by 2025, second only to China with 1.1 billion smartphones. But only an estimated 9% of all women in the country use social media. This makes sense in a context where only 14% of adult women in the country owned a smartphone in Q1 of 2020, and only 21% had ever used the mobile internet. Wealth and education are the strongest determinants of mobile access, but gender norms also play a powerful role. Today, I'm going to share some of the lessons that BBC Media Action has learned from designing and scaling one of the largest mobile health communication programs in the world and transitioning responsibility to the Government of India. In 2011, we were working in partnership with the Government of Bihar and the Bill and Melinda Gates Foundation to shape demand and practices around reproductive, maternal, neonatal, and child health outcomes. One of BBC Media Action's core values is that the communities we serve are at the heart of everything we do, which means we use a human-centered design approach in all of our work. Our research revealed that more than half the women in Bihar were illiterate, with little access to mass media, but almost 80% of households and 90% of frontline health workers owned a phone. However, these devices were overwhelmingly basic. Basic phones and digital literacy levels were incredibly low, with only 9% of frontline health workers having ever sent an SMS in 2011. Based on these findings, we knew that we needed to develop something easy to use and audio-based. We chose interactive voice response technology, or IVR, because it overcomes the challenges of low literacy and limited digital skill by providing access to audio content on any mobile device through a simple phone call. Additionally, because women were likely to share their husbands' phones and had low or no decision-making power over their own or their children's health, it was imperative to design content that engaged fathers just as much as mothers. We developed the complementary suite of mHealth services as part of a single theory of change. This theory of change was based on the premise that providing timely, accessible, accurate, and relevant information improves knowledge. However, while knowledge is necessary, it is insufficient to change behavior. Negotiations between frontline health workers and families are critical to improving the self-efficacy of those families. Discussion is often a gateway to change. And increased knowledge and better interpersonal communication skills will make frontline health workers more confident and motivated. The resulting suite of mobile health services are Mobile Academy, a mobile training course to refresh frontline health workers' knowledge of RMNCH and improve their interpersonal communication skills. Mobile Kunji is a job aid to support frontline health workers' interactions with families. And Kilkari provides pregnant women, new mothers, and their families with timely, accessible, accurate, and relevant information about reproductive, maternal, neonatal, and child health. Kilkari makes an outbound call with pre-recorded audio content directly to the subscriber's mobile phone from the second trimester of pregnancy until the baby is a year old. All three mHealth services are delivered by one voice, Dr. Anita, to humanize the user's interaction with remotely delivered pre-recorded audio content. Our research revealed that due to gender norms, fathers wanted to hear from an authority figure they could trust. Mothers wanted advice from a credible source too, but they also wanted empathy. Dr. Anita's tonality was crafted carefully, ensuring the right, delicate balance between empathy and authority. And with the support of the Ministry of Health and Family Welfare, Dr. Anita was able to journey beyond the borders of Bihar. Much of the vocabulary used in official health communication is often complex, making it difficult for low-literate, low-income women to understand. Concepts we take for granted can be completely alien. For example, many women respondents had never heard of, let alone used, an ambulance. Many had not heard of zinc. To resolve this challenge, we developed a dictionary of common health terms, which we repeatedly tested until we had a lexicon of words, phrases, and even explanations of concepts that could be understood. In 2013, the National Health Mission approved the national scale-up of our mHealth services for frontline health workers. In April 2014, it asked the Bill and Melinda Gates Foundation and BBC Media Action to support it in scaling all three services. It took 6 months to agree roles and responsibilities, and work kicked off in October 2014. However, shortly before the launch, the ministry decided not to scale Mobile Kunji, our job aid for frontline health workers, because it was thought that most frontline health workers would have smartphones soon. While this left a significant gap in our ingoing theory of change, the two services selected for scale were complementary, with Mobile Academy focused on improving the skills of health workers and Kilkari going directly to consumers. In January 2016, the services were launched by the ministry, hosted in a national data center near Delhi. Roughly 3 years later, Kilkari was the largest maternal messaging program in the global south. We achieved this level of scale by integrating Kilkari with the government's national databases that register pregnancies and births in India. When a woman's pregnancy or the birth of her child is registered, along with the mobile phone number in these databases, this record is shared with Kilkari. Kilkari uses the date of the woman's last menstrual period or the child's date of birth to create a stage-based, time-sensitive schedule of weekly audio messaging for up to 72 weeks. Our design research indicated that most IVR services are too complex for poor, uneducated rural women to navigate, so Kilkari requires no navigation at all. It is an outbound service, which means subscribers do not need to make calls themselves. A call is made to them. Government of India mobile services are exempt from consent regulations. However, every Kilkari subscriber can unsubscribe from the service immediately at the end of every call. Our design research also showed that users preferred to receive calls at a time of day that was convenient for them. But for the national version of Kilkari, this had to change. Calls had to be made throughout the day to maximize the government's investment in telecom infrastructure, to mitigate the challenges of poor network quality, dead batteries, busy working days, and the phone not being at home. We developed an algorithm to try, retry, and then try users again. It automatically calls the same subscriber multiple times over the course of 4 days. until the call is answered. This algorithm enables Kilkari to reach 80% of all subscribers. BBC Media Action, in close collaboration with the Gates Foundation and the Government of India, led the national scale-up of Kilkari, coordinating with a large consortium of partners. As we worked together to design and scale a new national version of the service, it became apparent that additional funding would be required to cover activities that the government might struggle to procure. So we brought in investment from USAID and the Barr Foundation to supplement the funding from the Gates Foundation. The Government of India's investment of $2 million paid for call costs and the data center for 3 years, which were crucial in ensuring scale. As of April 2019, when we transitioned responsibility for Mobile Academy and Kilkari to the national government, 206,000 frontline health workers had successfully graduated, and Kilkari had reached 10 million subscribers. Thank you.